wanted to introduce our next panel, which is what troubles the 50-plus woman's heart. Now, all of you know that things don't start and stop at 50. I mean, 51 is the average age of menopause. We all know in the United States. But there obviously is this is a little bit of an artificial kind of division. But we did want to talk today about what tends to happen in younger women and is more likely in older women. And it seemed a logical way, but we hope you'll see from our panelists that there's a lot of crossover and things can happen to younger women. Our moderator today is Dr. Jonathan LaPook. He is the medical correspondent for CBS Evening News with Katie Couric. Recent studies that stories that he's covered is some of the new brain scans to rule out Alzheimer's and Arizona Representative Gifford's treatment and rehabilitation. In addition to his reporting work, he's an associate clinical professor in medicine at Columbia University Medical Center, where he combines teaching and clinical practice in internal medicine and gastroenterology. So we're not too far, heart and yeah. The key to a man's heart is through their stomach, right?
That's good.
Joining him on the panel is Dr. Ileana Pena. She's a professor of medicine and epidemiology and biostatistics at Case Western Reserve University in Cleveland. Dr. Chet Rehal, Chair, Division of Cardiovascular Diseases at Mayo. Dr. Alexander Lansky, Director of Yale Women's Heart Center in New Haven, Connecticut. Dr. Noel Bairey Merz, who's Director of the Women's Heart Center at Cedars-Sinai Medical Center in Los Angeles. And Dr. Patrice Nickens from the NHLBI, who's Program Director for Heart Failure and Arrhythmias. So I will let Dr. LaPook and our panelists come on up.
Oh, are you all coming up? I'm here. Are we doing one at a time and then, or everybody at once? Okay, so I guess we're all coming up. Hi, everybody. We've been told it's like a well-oiled, but low-fat, low triglyceride oil. High omega-3 oils, healthy oils. No trans fat oils. Hi, everybody. So our charge is to make this interesting and interactive. And excuse me. We were just chatting outside, and I said, as members of the media, we're always oscillating between our instinct to jump on the bandwagon and to blow the bandwagon up, you know. And each one of the panelists has a topic that we'll introduce. And I said to them, to make it interesting for us as members of the media, I think what we want to know is, you know, how do we get it wrong? So I said to them, first of all, for each of these topics, come up with the headline that just drives you crazy. You know, so so they'll come up with that. We want to make things interesting. On the other hand, we all know the topics that make us go crazy. When another reinterpretation of the WHI study comes, you know, we hang our head and, you know, how can I tell this in a way that doesn't make the viewer take a brick and throw it through the television set? So the other prism that I asked them to do is, as you're talking about these, think about, in terms of how we tell this story to our audiences, what's the message? You know, what should they do differently? How do they diagnose this? Does it really matter that they know it or they don't know it? Should they be changing their lifestyle? Should they be popping a pill? What do they say to their doctors? So try to look at it through that prism. And if you can sort of pipe in as we're talking, interrupt. I was told that by the end we should all be yelling at each other, and you know, it's like one of these cages, you know, with the wrestlers. No. Not quite that, but we don't want it to just be sterile where one person's talking. So just, you know, interrupt, shout out questions and things like that. So we're going to start with Dr. Ileana Pena, who's going to talk about heart failure in older women, and maybe just give a quick spiel. We said no presentations, there's no PowerPoint, but give a quick spiel about, you know, what exactly are we talking about. And then at the end of that, maybe give me your, you know, what drives you crazy headline, or just, you know, how do we get it wrong? What's the biggest misinterpretation? And then we'll go from there.
So everything that you heard from the previous panel and all the different manifestations of heart disease, I'm sort of at the tail end. Why? Because all those syndromes can end up with heart failure. So heart failure is the inability of the heart to pump enough blood to meet the needs of the rest of the body. That's in general. Why does it apply to women? Well, there's a lot of interesting things about heart failure in women. Number one, we know that the number of hospitalizations for heart failure in women keeps going up. It's not well recognized by a lot of physicians that the symptoms are identical to, say, the man who has had a heart attack in his 50s. Shortness of breath, fatigue, the pump isn't pumping. But then when they look at that ultrasound, hey, the pump looks like it's pumping. The problem is it isn't filling, but it's heart failure. And it is the heart failure that is much more common in women, particularly older women, and now makes up about 40% of our admissions into the hospital for patients who come in sick. It is also a cause of having patients come back within 30 days, which right now in this country is just not acceptable. And many of those, in fact, are women. The unfortunate part of it is that type of heart failure, we really don't know what drugs work. We do know that keeping blood pressure controlled is critical, and you heard about that from our earlier panel, but we don't have the next best drug for that type of heart failure. And as a matter of fact, the NHLBI is doing a very large study to look at that type of heart failure that is so common in women. So women do get heart failure. It should not be ignored. The symptoms are important. The symptoms are identical. And the morbidity, namely the disability, the quality of life, and the rehospitalizations is huge.
When you see delay in diagnosis, I'm an internist too, does it differ between men and women? I mean, is it because, do we get faked out because of what?
Yes, I do think that delay happens, and us women always try to put our sort of our emotional part into our history taking. So I try to teach the residents that listen to the symptoms. And there may be an I'm very short of breath. I can't lie flat at night. However, you know, the kids have been giving me problems, and my husband is now ill, and I have all this responsibility, and there's stress at work, and maybe the focus on the clinician immediately goes to the emotional, and the symptoms are ignored. So I think we need to teach our physicians, our medical students, and especially our residents who are about to go out there and meet the world, to listen carefully and culturally sensitive listening.
What headline drives you crazy? Or is it not covered enough to have a headline?
Well, there are things that drive me crazy, and I see little groups of big studies being singled out as being very important and very critical. And that's not necessarily the science. The science is the totality of the science. So I saw recently in an email about biventricular pacing working better for women. Well, that was a subgroup analysis of one study where the number of women was smaller, and you really can't make big extrapolations, but it makes headline. And the headlines are taken as truth. So I'd like to hear clinicians go to the study and actually look at it, and that drives me crazy.
Only medical correspondents do that.
Okay.
Read. It is true that that made a big headline, and so often when you go back to the original article, it's you know, where's the beef? Okay, we're going to go through, I was told, relatively quickly, because then we want we can talk about various syndromes, but they all do come together in one organ. So we want to then, at the end, talk about how they interconnect and interact. So the next person, Dr. Chet Rihal, is going to talk about apical ballooning syndrome, and I could even make up the bad headline for that, but I will leave it to you.
All right, John, thank you very much. It's a pleasure to be here with you all this morning. Thank you for coming. Thank you to my colleague Sharonne Hayes for organizing this great event. I've been asked to speak a little bit about a topic that I've been interested in from a clinical perspective called apical ballooning syndrome. And I'm going to introduce it to you by telling you a story. So I'm an interventional cardiologist, and what I do is I open up arteries with balloons and stents for a living, particularly during heart attacks and those type of problems. Mm-hmm. And almost 10 years ago, I distinctly recall meeting a patient who showed up in our emergency department, a male, 70-year-old man, who had a heart attack. We took him to the cath lab. We found the blocked artery. We quickly opened it. The patient did well. But that's not really the story. Almost 24 hours later, his wife showed up with the same syndrome in the emergency department. She came in, chest pain, electrocardiogram was abnormal, the blood tests were abnormal, and we took her to the cath lab expecting to find the very same thing, that the artery would be blocked and that I would have to open it. But in fact, the arteries were wide open. And so we were scratching our heads trying to imagine what's going on here. But she was really quite sick. Her blood pressure was low. She was in incipient cardiogenic shock, which is a type of heart failure like Dr. Pena is talking about. So we took a picture of her left ventricle. The heart is a pump, as you've heard. Its role in the body is to pump blood around. And we found that over half of her heart was literally paralyzed. It wasn't moving at all. It was just sort of frozen, and a little bit of it was contracting like this at the base. So the part that was frozen is called the apex, which is a part that you might be able to feel kind of hitting the chest wall. And, we couldn't understand what was going on here. There was nothing obviously causing the heart, from a physical standpoint, to be paralyzed and to be so impaired. So we treated the patient, and the other thing that we were amazed at is about 48 hours later, her heart had recovered entirely. It was totally normal. She was out of cardiogenic shock. She was stable, and in fact went home shortly after. Her husband actually took a lot longer to recover. So we were confronted with these two patients. One was a man with sort of a standard heart attack that we may see in every hospital on a day-in, day-out basis. And the other was a relatively rare condition that affected her and was a life-threatening condition, but yet she recovered fully. And we subsequently came to understand that this is what's called stress-induced cardiomyopathy. So the stress of having her husband hospitalized and going through this major medical issue somehow caused a very high epinephrine surge or adrenaline surge in her body that negatively impacted her heart's pumping function. And the adrenaline, rather than making her heart stronger, for some reason shut it down. So this is what's called stress-induced cardiomyopathy. It's also known as left ventricular apical ballooning syndrome. And the thing that drives me nuts, it's also known as broken heart syndrome. Okay?
Right.
So if you look at the media, it's a catchy phrase, but it doesn't really convey the full picture. Now, once we observed that same patient, we then started collecting a series, set up a registry. We started collecting a series of patients, and we published a number of papers on this. And we've discovered a few important things. One is that the vast majority of patients are postmenopausal women. Mean age is usually about 65 to 70 or so. There's very few men, less than 5% of cases, that can present with this. So there's something about the postmenopausal woman that increases the susceptibility to this high adrenaline or epinephrine surge that the body will kick out. We don't exactly understand on the cellular level why this happens. There's lots of theories and lots of research being done on it, but there are some tantalizing clues. So at Mayo Clinic, we've done some research into this. My colleague Amir Lerman has done a fascinating study where he looks at the vasoreactivity of blood vessels, and that's medical jargon. And what it means is how constrictive are your blood vessels? If somebody is under stress, your arteries go, do they shut down or do they open up? And there's different ways to test this, including a little finger probe. So what he did, he took a number of women who had suffered from this apical ballooning syndrome and compared them to a number who had had regular heart attacks from blockages. And then he did intense psychologic testing that's designed to cause mental stress. And what that test is called the Stroop effect, where you have a word like the word red, but it's written in blue, and you have to say blue. You don't want to say red. And that's incredibly stressful to do. And what we found, you should try it. It's actually quite stressful to do. And what we found is that the women who had suffered from this apical ballooning syndrome, their arteries went like this during this psychologic test. Whereas the ones that had heart attacks, they also constricted, but not nearly to the same extent. So there's some tantalizing clues that there are some of us, or some women, who are more prone to having these type of problems, whether it's an emotional stressor or even a physical stressor. It could be an operation, a car accident, getting some sort of medical procedure that in turn will lead to this massive adrenaline surge that can cause this.
Can you give us a sense of the order of magnitude? How many how many women a year out of how many cardiac-related chest pain syndromes? How many of them do go on to get heart attacks? How many die?
Yeah, it's a relatively rare but important condition. At our center, we see about 1 woman per month.
Well, we're talking nationally, is it like 1 to 2% of all of the?
We honestly don't know. We don't know. And the reason we don't know, John, it's like less than 1% of patients with heart attacks. But the reason we don't know is that it's under-recognized. You see, it's the difference between seeing and observing, right?
But is the natural history different than, say, with atherosclerotic, with a blocked artery?
Again,
They tend to have a better prognosis than women who have underlying...
Well, it's interesting. What we found in our experience, there's a 10% recurrence rate up to 4 years.
But are they less likely to drop dead? I'm sorry to keep interrupting.
Yes, they are a little less likely to drop dead. The good news is that this is a transient or temporary paralysis of the heart, and that the heart's pumping function does recover. And we can differentiate that by using sophisticated scans such as magnetic resonance imaging. So getting an MR scan can clearly show the difference between a regular heart attack and an apical ballooning stress-induced problem.
So the headline that drives you crazy is the Super Bowl kills, right? Especially if you're a Jet fan this year.
Or a Vikings fan last year, let me tell you.
And how does our viewer look at this and say, okay, I get this, now what? Or if you're that resident in the emergency room, how do they react differently because of the knowledge of this? Do they do a different test? Do they have it? What do they do?
The key need that we have is education, of the cardiology and the physician community. The level of awareness of this still isn't where it should be. And, people in emergency departments need to be able to recognize this. Cardiologists need to be able to recognize this.
But why does it make a difference? If you're not doing anything differently, why does it make a difference to recognize? I'm obviously playing the devil's advocate, but why does it make a difference?
Yeah. Well, the question is, how are you ever going to understand how to treat it if you don't know? Right? So the first thing...
But do we think that it makes a difference that you treat that this way and the other type of heart attack that way?
Yeah, we don't know the answer to that yet. Yeah.
Okay.
There's a lot of unknowns.
All right. So where I'm getting a little thing saying, move along. Move along. But that was excellent. And obviously jump in with any and all questions. Okay. Dr. Alexandra Lansky from Yale is going to talk, who was at Columbia at my institution until a little while ago.
So first of all, thank you very much for having me here. It's a pleasure to be here. So I'm going to start with the headlines. The headlines that drives me crazy is heart procedures kill women, or heart procedures kill more women than men. And to me, this is sort of the fatal blow because it leads to somewhat of the problem that we're faced with. So the reality is that if you go back in time, and my colleague to my right is an interventionalist and does many of these procedures, go back in time about 20 years, it is true that the outcome of women undergoing percutaneous coronary interventions for obstructive coronary disease was not very good. They actually did have a higher mortality rate, both in the hospital and if you followed them out to 1 year compared to their male counterparts. Well, let me tell you, there's been a lot of progress in terms of devices and in terms of technologies and pharmacology that is used in the cath lab, such that nowadays when you're doing an intervention on a female patient, the outcome is just as good as in the male patient. In fact, these procedures are life-saving. So just as the example we just heard, a female patient that comes in with a heart attack should be taken to the cardiac catheterization laboratory immediately, and the sooner they get there, the greater the benefit in terms of reducing mortality. So that's sort of, my pet peeve in terms of trying to change the message, because I think there's a misunderstanding in terms of the risk associated with the procedures. Now, I think another important point to highlight is there's a signature. Female patients that come into the cath lab have more risk factors. So they're older, they have more diabetes, more hypertension, more risk factors. Yet when you look at the coronary angiogram, there's less extensive coronary disease. And this is somewhat of a paradox because we don't really, I don't think we put all the pieces together to try and explain, here's a higher risk patient population in terms of all the clinical risk factors. Yet when you look at the extent of coronary disease, it's actually lower compared to male patients, and I think my colleague to the right is going to address this.
And they have more risk factors because they get their heart syndromes later.
Because it's 5 to 10 years down the road, and
they're older.
And in many ways, it takes more risk factors actually to have sort of an equivalent or even lesser amount of coronary disease. So I think the gaps, there are many, many gaps, but we need to understand why the outcomes are what they are, given the fact that the extent of coronary disease is less. So I think that's one big factor. There are two specific populations I believe are important to sort of highlight. One is the patient population coming in with myocardial infarction, so ST elevation myocardial infarction, where still to this day we're seeing a higher mortality rate in female patients in that population compared to the male patients. And the other population...
Is that because they're getting capped less frequently?
Well, there are delays to presentation. There, I think there's a multitude of factors.
But it's not that they both get cathed during the ST elevation and they have a worse outcome. It's that the time to doing that.
I think there are time delays. I think there are multiple factors that we can influence, and then there's a bunch of factors we still have yet to understand. Right. So that's number one. The other population I think that we should highlight is the younger patient population, so the less than 50-year-olds, where when you look at mortalities and you're comparing the outcomes of men to women, it's really in the younger age group that you're seeing an excess mortality. So as you go to older age groups, the mortality rates between men and women are very similar. So it's really in the younger patient population where we're seeing a twofold higher mortality rate in the young female patients. And again, I don't think we really understand what's going on in that patient population. Just a third sort of final piece to talk about, and I think that has to do with diagnostics. There are trials, and you've seen some of these reports basically saying 60% of patients going to the cath lab don't have any obstructive coronary disease. And I think it really comes back to our ability to diagnose CAD and some of the limitations, I think, in terms of diagnostic tests. And, we can sort of expand on that. But I think there are new things that are out there that we can,
I was going to get there, and I'm glad you brought it up because I want everybody to address this later. But obviously, we're in an era of evidence-based medicine. There's a clash between evidence and intuition, and this friction we're seeing all the time. We know that people who have ST elevation, acute heart attacks with EKG changes, if you get a catheterization, you get stent, you save that person's life. But otherwise, stenting hasn't been shown to prevent a future heart attack or to, decrease mortality. So, and the people at Dartmouth, Elliot Fisher et al., have shown, they estimate about 30% of angioplasties in this country are unnecessary. About 30%, that's a lot.
In men and women.
And men and women, in men and women. So how... I guess we'll keep going, but I'd love that those questions, are we being too aggressive? How do we, obviously one answer is how do we diagnose CAD as coronary artery disease? How do we diagnose that better so that we're not capping people unnecessarily? Right. Again, if you're that viewer out there and you're 50 years old and you're thinking, oh, now I'm getting an increased risk for heart disease, well, what about me? What should I do? Do I just go based on my cholesterol, on my bad cholesterol, my LDL? If my C-reactive protein is elevated by this Jupiter study, maybe I should be on a statin, maybe not. Should I get a stress test? Should I get one of these fancy fast CT scans to look at my heart arteries? But maybe I should just get my carotid artery ultrasound, and that's what's called a surrogate marker. If that has a little bit of cholesterol in it, then maybe there's some cholesterol in my arteries of my heart. What do I do? So I want to sort of put that as out there. Don't need an answer right now, and keep moving on, and we'll go from there. So Dr. Bairey Merz from Cedars-Sinai, spiel away.
So I was asked to talk about microvascular coronary dysfunction, which is, I think what I would sort of say, the headline that I would like to see is that recognition of female pattern heart disease is a real problem. And it goes to heart failure, and it goes to MIs and acute coronary syndromes, and it goes to chronic angina. And Patrice will tell us at the end. But there are clearly differences, sex differences in all of these cardiovascular parameters. Microvascular is just one, but microvascular probably explains at least half of that 50 to 60% of women that get up to the cath lab and have open arteries despite having a positive troponin, despite having elevated inflammatory markers, despite having an abnormal EKG, despite having clear evidence on good non-invasives of ischemia. So this isn't, we don't cath people just because they have a little chest pain. These are, we have pretty good advanced diagnostics.
So that's a very good example, actually, of something where education really makes a huge difference because, again, without getting too technical, there are things that you can do in the cath lab, giving adenosine and acetylcholine, that actually can help bring out this microvascular. So the big arteries are open, right? The tiny ones are closed. It looks like it's a normal cath, but the person actually does have significant tiny little blood vessel closure. Do you find that doctors need to be better educated in terms of?
Absolutely. And one of my pet peeves is putting women up on a pedestal and the testing is too dangerous or too risky, and yet we're able to put in stents, sometimes that probably are not evidence-based, and yet we won't have a clear diagnosis of a disease in a procedure that has very known risks and benefits and is safe in experienced hands. And so many women end up without a diagnosis given this lack of recognition of female pattern disease. So that would be sort of my mantra, is that the last, say, 25 years have clearly demonstrated differences between men and women in a variety of forms of heart disease that are, it's not the Venus and Mars, but it's a 10 to sometimes 20% difference. And when you're talking about something that kills millions of people every year, 10 to 20% difference is 50,000, 100,000, 200,000 lives. And a lot of those are women because we don't recognize female pattern disease.
Can you, we're assuming everybody knows that, but can you just give a quick summary of sort of the difference between how women can present versus men, and that's the 15 to 20% we're talking about, right?
Correct. So we didn't talk about heart attack signs and symptoms, but you did a little bit in the first panel. Two-thirds of men will have the Hollywood heart attack. I coined this frame. I didn't coin it. I stole it from Sharonne Hayes, who coined it, even though I'm from Hollywood. So
you will have coined it in the future when she's not around.
Exactly. We're a good team. No, but it sells very well in Hollywood. So the Hollywood heart attack is the classic Levine sign, shortness of breath, in the middle of the chest, boom, you fall over. You've seen it in the movies. That's true less than half of the time for women. So again, and atypical symptoms are as equally prevalent. So it could just be indigestion. It could just be extreme fatigue. It could just be some jaw or some arm pain. So that's female pattern recognition of disease. One of the other things to say is whenever we get into issues of, Noel, why are you always talking about women and heart disease? Remember, I said 2/3 of men present typically, but 1/3 of men present atypically.
Right.
You heard Chet say that, some men get this ballooning apical. About 20% of my patients with microvascular who have had heart attacks are men. So if we do a better job recognizing female pattern disease, we're going to take a better job of taking care of everybody, and it's really this personalized medicine approach.
Great. Okay, and finally, but not leastly, Dr. Davinia Nickens.
Thank you. I think
and maybe also say where you are in the world.
So that's relevant to my newsworthy headline that I dislike. So I work for the Heart, Lung, and Blood Institute, and I think the headline that probably has always given me the most trouble is the one that reads something like oxymoron government worker. And I choose that with all sincerity because the Heart, Lung, and Blood Institute, the NIH, is the major funder for key important health research in this country. And it is something that at the end of the day, certainly my colleagues, stand proud to say that we're a part of. You've heard in our panels this morning and this afternoon some of the important progress that has been made, but you also hear about gaps and what we still need to do, whether it's a small subgroup that we need to understand what we think we might have observed, or just to go further to really identify new and better therapies. The Institute, its mandate is to reduce cardiovascular burden, disease, and healthcare costs for the American public. That's a tall mandate, and what gets headlines and what is exciting are, the gadgets, which we have funded, and can, proudly talk about interventions, effective interventions, life-saving procedures, medicines that are now available as the result of research. Those things take time, but perhaps less interesting and less valued is what we can do immediately, and that is prevention. So I'm going to depart from my most exciting science portfolio, which would include clinical trials that have used new scientific discovery and have improved options for treating people with disease. But I'd like to bring us back to where we are. Let's talk a little bit about the demographics. This is about women 50 years of age. We're an aging society. Every day, 10,000 people turn 65. It's impressive. Over 20 years, that is by 2030, 1 in 5 Americans will be 65 years of age or older. So that's 72 million people, 65 plus, 20% of the population. So how do we handle this? Dr. Sebelius, I think Dr. Sharonne also underscored the likely tripling of costs, just slight increases in disease prevalence, which is what we would predict if we just maintain the current course. So of course research is very important to be responsive to not just a matter of economic needs, which of course is real, but also for those of us that know heart failure, heart attacks, these are things that rob us of our quality of life, not just longevity, but quality of life. Living with heart failure is difficult. We do have therapies that help improve survival, improve quality of life, but an ounce of prevention is worth so much more than cure. So I think it's really important for us to get back to the message that it's never too early, but it's also never too late to think about preventing heart disease. You must know your risks. I don't want to repeat what others have said today, but let me just remind you that if you have a single risk factor, it will double your risk. If you have more than one, it doesn't just double, it will triple your risk. If you have 3, 10 times the risk. So if you have family history, if you know of heart disease, high blood pressure, diabetes, high cholesterol, if those are things that you know happen in your family, these are things that you should be aware of. Those things that I just mentioned, that is blood pressure, cholesterol, and blood sugar, or diabetes, those are silent killers. You don't know that you have normal values unless you know your numbers. So it's really important that you know your numbers.
I'll make up the headline, I'm sorry, that should drive you crazy, which is that we, in the media, we love the study that shows that Lipitor will lower your LDL, or that some type of fancy procedure will diagnose heart disease, but it doesn't bring in viewers to talk about the Esselstyn diet or a vegan diet or losing weight or lowering the risk of diabetes. So we have people out there who are bragging about their LDL of 60, they're popping their Lipitor, they're 400 pounds, they have increased their risk of heart disease more by being diabetic and obese and having hypertension than they have by lowering the LDL. So what are you doing about that? Because that's really, if you could do that, if you could handle obesity and if you could increase exercise and all that, but
so do
you just tear out your hair and say, forget it, we just can't do that?
Well, clearly there is no pill or procedure that is a substitute for healthy habits. And so again, being physically active, maintaining a normal weight and a nutritious diet, low fat, low salt, avoid concentrated sugars. These are all important things that we can do and should do, not only for ourselves, but for our families. We should never smoke. And again, know your numbers. These are really effective measures that if you do now, it's like banking. You know, the earlier you do it, the better, but it's never too late. And it's an investment for your avoiding and protecting heart health in the future.
Do you think we're making any progress at all with this in terms of people doing better in terms of exercise and diet? Do you think we're making progress?
So it's too slow, but there are several programs. We know how to do this.
Right, but
it is simple. That does not mean that it's easy.
Do we really know how to do this? I would say that we don't. There was a Dan Buettner did who wrote about blue zones. There's this, I'm forgetting where it is, I think in somewhere in the Midwest, where they took a town and they just enlisted the whole town and said everybody's going to get on board. And so they talked to the schools, they talked to the mayor, they talked to the chefs, they put in bike paths, they put in walking paths, they threw out all the crap that was in the cafeteria. I mean, they said we can't, no matter how much we try, if you're living in a culture where there's crap, you could, like 99% of the day, your willpower's there, but then that 1%, boom, you can have 1,500 calories in 10 minutes. So they changed the whole, everybody was signed up, and they dropped their Blue Cross Blue Shield, their health bills 30% in 1 year. So I would, but we're not doing that in America, are we? I mean, okay, to talk about that.
John,
Cigarette smoking is under 10%
Trans fat,
in California. Trans fat is down. Public smoking was banned.
Smoking cessation
Exercise is actually up.
The one thing that has been shown to work, John, is not just smoking cessation programs, but as a matter of policy, instituting bans on smoking in public for restaurants, bars, pubs. And, for example, there's a great study from Pueblo, Colorado that showed a 30% decline in heart attack incidents. We've experienced the same thing in our county, in Olmsted County. It's not published yet. But public bans on smoking do work.
So I mean, I don't mean to be whatever. I do mean to be a little bit, but pushing it. But it's because the message that we keep saying over and over again, and I've talked with Betsy Nabel over the years, and we dutifully, as members of the media, we go up, we say, you really need to diet, you really need to do exercise. My friend Mehmet Oz is trying to stir things up in a more dramatic way, just to, do something different, because most of us are frustrated and feel we're blah, 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 blah. So the Charlie Brown thing, and all the parents are always, blah, blah, blah.
Well, let me interject here a minute. A lot of times when we think we're doing the large trial, this happened to us with an exercise trial, we don't often take the time to find out from the patient what they believe. First of all, we say to them, I want you to lose weight, I want you to exercise, I want you to eat a healthy diet. Do you believe me? It's called the health belief. And we never take that step. Because if they don't believe that what you're saying to them is true, they're not going to do it. No matter what, you can put it right in front of them, and they're not going to do it. All these diets, that right now on TV, they're very fashionable. They always kick up the advertising. And now that drives me crazy. They kick up the advertising early in the beginning of the year because everybody's guilty about the holidays because they ate so much, and here comes a beautiful star singing and she looks wonderful. When they stop the program, the weight goes right back up because their behavior never changed.
Now let's throw it up to questions. I'm seeing we have 15 minutes left. Barrage of fascinating questions, not to put any pressure on you. Controversial.
Have you studied the cities that have smog and particulate in relation to heart disease?
So there are good studies that do epidemiologic observational studies that do relate heart attack risk related to the level of the air quality. And there are actually some intervention trials from China. Beijing is one of the most polluted studies now, and they've done an intervention trial with, it was oxygen and a mask. Somebody help me here. And it worked. They had fewer heart attacks. It was a small pilot trial.
Less dating, but fewer.
Yeah.
So I just want to push this a little bit. Yes, hi, Elizabeth
Feely from Morehouse School of Medicine. The question about knowing what works and whether or not it works in everyday lives of individuals out there, and also the fact that clinical trials, when they're done, are done in the purest of populations where people haven't come with all of their real-world baggage and comorbidities and all of the social determinants of health. So the specific question, and I'd like Dr. Nickens to address this as well as any of you, is how about just doing a different, at least looking at a framework for clinical trials that take into account where patients actually are in terms of the real world?
Sure. Well, thank you, Dr. O'Philly, for your very thoughtful question. It allows two separate issues to come to bear. So one thing that is very important is inclusion, participation in clinical trials. We talked about beliefs, whether from, guidelines from your physician or even from your priest. It is health, behaviors are not things that are, that someone else tells you to do. You really need to believe that this is important for you, that this is helpful for you. And so wide participation in clinical trials, I think, is the best way for both the people that are designing the trial and working with patients to understand the complexity of lives and what's needed in order to answer a question. So I can't say enough, while we are doing better, we meaning clinical trials, for some time were criticized for not including, not being generalizable, especially excluding women. But in fact, we're doing better with that, but we need to do even better still, and we can do more. And especially when you're talking about behavior change, where attitudes and beliefs are certainly gender different. If you want to talk about different populations and culture and their, the conditions, if you will, in which we work, how even the simplest directions of how to, follow instructions, how things work within a context of where you live and how you do work, etc., is really important. So I can't stress enough the importance of general willingness of the public to participate in clinical trials. And then, of course, the other thing is that how do we design interventions? How are we thinking about what's needed? And behavioral research is very, very hard to do. And we have lots of programs that tell us that you can be successful. We know how to define the problem, how to monitor, how to encourage behavior, monitor behavior to reinforce that behavior. But knowing those things and actually being able to apply them is something that's very, very difficult. And in fact, the NIH has a motion, there's a group that meets that are trying to develop the tools to do better with this. But behavioral research, because we recognize that it is our healthy habits or lack of them that are going to be so important into in the future in terms of reducing healthcare costs and immediate benefits.
Are medical schools doing a good enough job of educating our budding doctors about sex differences, gender differences?
No.
No, not at all.
We're trying, but no.
And there's now a new organization called the Organization for the Study of Sex Differences. That's a society like the American Heart Association, like other, North American Menopause Society. And that is its mission, is to conduct sex differences, but develop curriculum and feed it into not only medical schools, but undergraduate. There are a number of programs now in Europe, so we're about 10 years behind, where you can actually get degrees now in the study of sex differences, sex and gender in biology and in medicine.
So that's obviously key.
Yeah.
I think the difference between talking about younger women and older women is that when you get older, other things impact your ability to lose weight and to stay active. Now, I have several friends who are trying desperately now to lose weight. But, when you're suffering from arthritis and your thyroid is going out of control and you have diverticulitis and you don't know what to eat, and what I see in some of my friends is that they get so depressed and feel so guilty because they're trying so hard to lose weight. One of them was on the phone with me the other day just sobbing because she had spent an hour at the gym on, on the elliptical and, still can't lose weight. So I think, it's all well and good to say, healthy life and, live, change your habits and all of this, but for a certain percentage of the population, especially women, what do you say to them when they're having such a struggle with this?
I'm not a behavioralist, but I would, to close the loop with this and what Elizabeth said, I think there are good examples of what we call social engineering, and you were describing this as well, which is called making the right choice easy and the wrong choice hard. And it's relevant to raising children, training horses. And when you look at cultures, societies, programs, clinical trials that have shaped an environment for the population, that works. When we say we know what works, that works. It is incredibly hard for individual people, and you alluded to it early. We make, I think it's like 100 food choices every day, right? Yeah. Every day. I mean, as you've been sitting here, you've been trying to figure out when you're going to be able to get to that food. And then as you go through the line, you'll make probably 30 different choices. So what if you have that weak will, 1 out of 100? Right. That's 2 pounds a year. Yeah. And then you're not going to be able to lose that in this environment. So social engineering, I think, is what we have to do.
I agree with, there's a book called Mindless Eating that you have to read about this, which is fantastic. And it talks about, there's trillions of dollars spent every year to make you eat when you're not hungry, basically.
Right. So John, what is the role of the food industry here? Because it's not just how much we're eating, but what we're eating and what's in what we're eating. Huge. And I think this is another side of the coin, or important piece of the equation that hasn't really been addressed yet from a policy standpoint. Yeah. And I've personally had friends who finished training in the United States and gone back. I had one went back to Tel Aviv, practiced there. Within 2 years, she had lost 30 pounds, said she was eating the same, not exercising more, but there was something about the diet, the dietary intake. And I don't know what it is, but there's something going on.
The single biggest thing is to get a smaller plate. Literally, you want it tonight, make a difference, throw out all your plates. If you go into an antique store and say, show me a dinner plate, it looks like our dessert plates. And there was a recent fascinating study where they showed by who were the most observant people of their generation? The artists, right? So they literally measured, this is so clever, how many calories were on the plates of people at the Last Supper over the years, and it just had, gone up gastronomically. Wow. So anyway.
Well, we may want to discuss the new USDA recommendations and how will the food industry handle those.
Absolutely.
So I'm loving the fact that the sodium content now recommended is close to what I tell my heart failure patients to do, which they find so difficult, and it's the way that I live with low sodium, but it's now also the trans fat and the sugar. And we need to realize that every time you see low fat in a box, it's high sodium, because something has got to appeal to the flavors so that people will eat it. And if it says low sodium, it's probably high fat. So one thing that I think we can do for our patients, teach them to read the labels. The labels have it. It's in there. You take the time to read the labels. And in our education booklet, we have actually put in there a label and put arrows to the areas that we want them to pay attention to. So that's something to help, for example, your friend who is frustrated. And I think the second lesson is, let's stop the guilt. Because more diets fall through because people feel guilty. And yet, it's okay to go off the diet one day as long as the next day you recover and you come back and do it. So I have a girlfriend who's a behavioral psychologist who's been educating me about all this when our large trial, didn't give us what we wanted. She says to the patients, fill up your plates like you would normally for dinner. Then take a knife and cut it in half. Store half for your meal tomorrow and eat only half of what you thought you were going to eat, and you will probably be satisfied. So simple tools.
Yeah, we have a question over here.
And it's a question and a comment, because when we started this panel, we were talking about how these conditions that were different or unique to women. And how did we find that out? well, observant patients, observant physicians, and federally funded trials as the WISE trial, which was funded by the NHLBI. And I think that it was one of the points I made early in the day is that this is the women's health issue. And I can tell you that when we have a hormone trial or a breast cancer trial, prevention or mammogram trial, there are women lining up down the street to sign up to be a part of it. And we have to dig and dig and dig to have women participate in heart trials. We have to give them extra money, we have to give them car fare, we have to do, now, so these are barriers, and I think we need to help women understand, and I have an example because my mother, when I said, oh, you should, my doctor asked me to be in a clinic, it wasn't a heart trial, but why would I want to do that? And I said, Mom, because you don't work, you're retired, you've got the time, and you know, and why wouldn't you? But my mother is a college-educated woman, and if she's not thinking that clinical trials are relevant to women, that is a message that all of you could get out to women, not just heart disease, but even though we're trying harder, only about 25% of clinical trial participants for heart disease research are women. We're not going to learn about them.
And you've heard by many of our speakers today, more than the majority of deaths are in men, not women, are in women and not men.
Because
and yet our trial, so you would expect a trial of heart disease of any kind to have at least 50% women, but instead that number is 25. And there are some real reasons. The reason we give, at least in federally supported research, we've identified issues that are real barriers for women. Time management, as mentioned earlier today, we're very busy. We are often in charge of so many things. And an appointment in the middle of the day doesn't work as well. Child care issues. But women are often underinsured. Women are often below the poverty line. And so sometimes being underinsured is a real barrier for participation in a trial. Not being able to get there, transportation back and forth. And of course this concern about if I'm not there, who's going to take care of the family? These are all really valid, important issues that women face when thinking about participating in something that is considered optional, but participating in the clinical trial.
We have time for two. I'm sorry. We have time for two questions. Sorry, I know you've had your hand up, and I know we have a question over there. So
I just wanted to make a point about funding of clinical trials because Dr. Pickens can't actually advocate herself here, but we all can. And the fact is that, I mean, if heart disease is the #1 health issue for women, can you imagine if there was a headline saying that breast cancer research funding was going to be cut, or that ovarian cancer research funding is going to be cut? Well, what's going to happen is when everyone hears discretionary funding cuts in the next several weeks, that's the cuts that we're talking about. We're talking about the cutting of those kinds of research trials, but they're not necessarily women don't connect with heart disease and those research trials in the same way, so you don't have the same kind of advocacy. I'm with WomenHeart, the National Coalition of Women with Heart Disease, and advocacy is a big part of what we do. So I just think, again, for the media in the room, this is not just some policy debate going on in Washington. This is where the cuts are going to happen, unfortunately, unless we speak up and can identify.
we have literally 1 minute left, and we have one question over here.
Hi, I actually had a question about diet because I know that portion control and making wiser, healthier food choices are great on the preventative end. But what happens when you have heart disease, like my mother has, and then she eats kale and greens, and her coumadin gets all wacky and things like that? So what kind of medical research is being done for options for women to eat foods that are complementary to the cocktails that they're taking every day so that it helps her as opposed to putting her back in the hospital?
There's a concrete answer and a longer term. There's the Bigatran answer, and then there's a longer term. So why don't whoever wants to take the last?
Well, just in terms of the greens, I'll take that one on. My approach has always been eat the greens because those are healthy for you, and then adjust the coumadin afterwards. So that's always been my approach.
If you eat the same amount every day.
I'm not a proponent of saying cut out the greens and let's get that coumadin.
There's also a new medication, Dabigatran, that may make it so you don't have to worry about diet. But what is the longer term thing about diet and heart disease and how we get people, and we're out of time.
Well, a very low-fat vegetarian diet has been shown to reverse heart disease. So, did you hear that? Reverse?
Yeah.
Can
this
it
is
reverse?
Esselstyn's book and others, obviously.
So diet is actually critically important and too often not fully attended to. And for those of the folks that we were talking about earlier that sort of eat their way through Lipitor, well, David Blankenhorn did a wonderful study with his original class because he was very careful to measure nutrition as well as the lipid-lowering statin effect. And about half of the benefit was nutrition and half was the statin. So anybody that doesn't attend to both of those halves, take your pill, attend to your nutrition, you're missing out on half of a possible benefit.
Thank you to everybody here on the panel, and thanks to everybody.